So 3 out of 4, 77%, die of things like dementia. End-stage heart disease, end-stage lung disease, end-stage kidney disease. Chronic diseases that don't have a predictable trajectory, like cancer. So the hospice model doesn't even work for 3/4 of us, because the hospice model assumes that we can predict who's dying, and we can't. So that's why we need to have this simultaneous care model. Now, Judy was the exemplar of advanced care planning. She not only thought about what would happen several years down the road, she took action. She talked to her family. She talked to me. She talked to her oncologist about what she wanted, what her wishes were. She made sure her healthcare proxy knew what she wanted. There was really no anxiety or guilt or debate about what to do, because Judy wrote the map and the rest of us followed it. And that kind of discussion took place years before she died. Not at the end of life, but in a very planful, conscious way, and in a way that I think allowed her to live very fully until the very end, because she took care of that and she put it away, and then she lived. So I would argue that non-hospice palliative care is appropriate from the point of diagnosis of any serious illness. Whenever there are symptoms, functional burden, family burden, and there's enormous family caregiver burden associated with these illnesses, regardless of how long a person can live. Now, my Mrs. G patient lived for, when I met her, she had dementia. That was part of the problem. She was really unable to anticipate the future coherently. That's part of the reason why she wouldn't appoint a healthcare proxy, part of the reason why she wouldn't talk about the future, because she no longer really had the cognitive ability to do so. And that was 15 years before she died. Okay. So people live for a very long time with these diseases nowadays. And I did keep her going with life-prolonging treatment for 15 more years. It was very effective. It was what she wanted. It was what her son wanted. The dementia progressed, but the body remained. And hospice, as I mentioned, when life-prolonging treatment either no longer works or its burdens outweigh its benefit. And the result, and there are now quite a few studies demonstrating this, is markedly better quality of care as reported by patients and families, and care that actually matches the needs of patients. Right now, we very often get care that, as I said, falls into a glide path that is not particularly relevant to what people need, like happened with Mrs. G. So Art Buchwald, you guys probably remember him. He died a couple years ago at age 81. This is from his obit in the New York Times. As he continued to write his column, he found material in his own survival. So far things are going my way, he wrote. I am known in the hospice as the man who would not die. Now, he died of kidney failure. People do not die on schedule with kidney failure. A year after going into hospice without dialysis, there he was, doing fine, holding court, having the famous from all over the world come visit him. And in fact, he was thrown out of hospice for failure to die. And that's what the Medicare hospice benefit requires. It's considered fraud and abuse if you take care of a patient who fails to die. So he failed to die, so he got thrown out. I think eventually he got back on, but how long they allow me to stay here is another problem. I don't know where I'd go now, or if people would still want to see me if I weren't in a hospice, and that relates to that framing issue that the rabbi mentioned, that the fact that he was labeled as dying brought all this love and care to him. Had he not been labeled as dying, he wouldn't have gotten it. It's very interesting that he pointed to that in this quote. But in case you're wondering, I'm having a swell time, the best time in my life. And I think if you look at those pictures of Judy, you can see that she was as well. What an incredible hunger for life and ability to savor it she had. And then Isaac Asimov writing about 20 years ago, life is pleasant, death is peaceful. It's the transition that's troublesome. And that part is under our control. Death is not under our control. What happens in the weeks and months and years before we die, that is under our control. And I hope that I've given you a vision of what we might work towards. And then there's old Helen Keller. This is my favorite quote. She wrote this great book called Optimism, which I commend to you among all the other books you now have on your homework list. This one's pretty wonderful. And she wrote, although the world is full of suffering, it is also full of the overcoming of it. And when you read the paper, all you see is really bad news and terrible things happening. And I guess that's because it's newsworthy, or controversy or sad stories get attention. But there's a great many wonderful things happening that human beings do. And the palliative care movement and the hospice movement and healthcare in general are one example of that. And there's Judy and Sarah and George. And I'm going to ask George to come up and join me up here now. And hopefully you guys will think of some questions for both of us. But I'm going to begin with a few questions for George. Thank you, George.
You're very welcome. I get to say one uneditorial thing. Diane's my hero.
So is this right, George? You're now teaching health policy?
Yes.
Since we first met?
Yes.
And you teach about this for students?
One lecture a semester in a graduate course on healthcare policy is devoted to end-of-life care. I check out my class first, but I've been able to use my personal experience, not get any bad blowback for being personal in a somewhat impersonal setting. And I present some slides. There's a conference Diane participated in, some of the slides you see up here. I talk about the experience, and I am a bit didactic. I do get in some of the policy issues. But mostly I say this is something that people need to be thinking about and preparing for and fitting into that very crowded healthcare agenda we're working on right now.
And as probably is unnecessary to mention, that everybody here remembers the death panels of last summer. There was some really important legislation that got dropped last summer because of that ridiculousness, like workforce. More people like me, because eventually I am going to have to retire and read novels. And we need young people coming into the field, doctors, nurses, social workers, chaplains, and there's no workforce provisions for this field. And there were, but everybody ran scared after the August recess. So we have some policy work to do.
Yes.
Anyway, George, you want to tell us a little bit about what Judy was thinking when why, given that she had what I think everyone would agree was probably one of the best oncologists on the planet, did she feel the need to seek additional support?
Well, there was a very simple answer to that question. He did not want to have the time or have the ability to talk about preparing for end of life. I don't think he saw it as, I shouldn't say, I don't think he quite saw it as part of his responsibility. He was a wonderful doctor. I walk by his center on my way home most evenings. I keep hoping to see him. I've had a couple of contacts with him since Judy passed away. We love him. We respect him. We give him tremendous credit for the 6 years together that we enjoyed, that we didn't expect to enjoy. But he could not have that conversation. And if the one thing about my wife that everybody knows is that if she wants to talk about something, she is going to talk about it. She will find a way to do it. There was no stand-in for me, so I had to learn to talk a lot. But Diane was available to help with end-of-life issues. We found Diane in a somewhat random process. Judy came across something in an article from 7-8 years ago in AARP about you, a brief note. And she said, I was the internet consultant, so to speak. She said, find her. So I came back with two numbers, which I now understand. One was your faculty office number, and the other was the Palliative Care Institute number. She called the faculty number, and your secretary put her through, and you were talking, and a relationship was born. It was fortuitous, but it was wonderful. And Judy had her questions, had her thoughts. We had discussed them, and it was, well, for myself, I can say it was a huge relief to meet Diane, because I was feeling, perhaps even more than Judy, she had the sadness of knowing that she was approaching the end of her life. But I had the burden of trying to figure out how to deal with certain things that I could see I was not getting enough help with at NYU Medical Center. So it was just a wonderful experience to meet Diane.
I want you to tell us a little bit about what happened when the oncologist, as things were getting worse,
Right.
some months after or even a year after I met Judy, she went back to the oncologist, and he offered some additional treatment, including administration of chemotherapy directly into the brain, because there were brain metastases. And Judy checked back with me, what do you think? Was that the...
That was a very much a significant event. The oncologist, we had pretty much gone through the pharmacopoeia of chemotherapies. Newer, trial, older, oldest, and there we were without really alternatives to address this increasingly aggressive cancer. And he suggested a consultation with a surgeon who would insert what's called an intrathecal catheter, an implant to the brain which would directly deliver chemotherapy. We went to see a surgeon. You know, surgeons are very, very, very confident people. I had read the statistics. I knew it was not an unsafe operation, but not the safest of operations. And even the surgeon said, oh, you'll be fine. There'll be no complications with the surgery. I do more of these than anybody. I'm the only one at NYU Medical Center. But he evinced a little doubt about the wisdom of the treatment. We had that inkling as we were thinking about it, because Judy was on her feet, mobile, and still getting around, albeit slowly, but there would be a tremendous change in quality of life attached to having a catheter put in your head. And it just didn't seem quite right. So we went to Diane and we said... Right.
So then my first reaction internal was, that's ridiculous, which I did not say out loud. But I did say, let me call Dr. C and talk to him, and I did. And it was really one of the most profound conversations with a colleague I have ever had, and taught me more about what needs to be healed in the healthcare system than any other single 20-second exchange. So I said, Abe, Judy mentioned that you had thought the possibility of it's called an intrathecal pump because it goes right into the brain, might be useful. And I asked him, what are you hoping we can get from this treatment? There was a pause, and he said, I really don't think it's going to help her. And I said, I paused, because my initial reaction was, like, why do you recommend something you don't think is going to help? So I said, well, she asked me to talk to you, and she asked me what I thought, and, what do you think I ought to tell her? Do you think I ought to encourage her to go ahead with this? And here's what he said. He said, I don't want Judy to think I'm abandoning her. Right? So the only way he knew how to not abandon his patient was with more treatment, because that was all he was taught. He didn't know to go to the house. He didn't know to just sit and thank her and listen to her thanks. It wasn't in his training. So to show her that he cared about her and that he was not going to abandon her, the only thing in his armamentarium was to give her chemo into the brain. So it's interesting because as soon as he said it out loud, this is the power of naming. As soon as he said it out loud, I don't want Judy to think I'm abandoning her, it was obvious that this was not what we were going to do. And we both agreed that we collectively were not going to make that recommendation to Judy and George, and we didn't, and she turned it down, and that's the point at which hospice was brought in. But I think there's a world of information in that statement about the really good intentions of the healthcare profession and the desire to help patients that activate nearly all health professionals. It's not about money, even though the press might have you think that it is about how to care for one another. And the problem is this oncologist, like most other doctors, didn't have any other tools. So I want to stop and take some questions. Yeah, are we out of time?
We're not out of time, except the rabbi is going to have to leave in a couple of minutes. So let me take this opportunity to first thank both of you for a tremendous, tremendous job. Stay right there. So rather than just take questions for Diane, we'll take questions for everybody. You usually get transformed in some way. The potential is in any human experience. Today was particularly, I thought, transformative, both on a spiritual level as well as a material level.
Right, exactly.
Thank you.
You're very welcome.
Okay.
You go ahead.
Okay, so, and your instinct about email, sometimes go with your instinct. Questions? Yes.
My question actually intersects both of your presentations. So I do work with elderly people at the end of life, and I try to do events planning to end of life care. I'm a social worker, so I try to initiate a conversation about it. And many events, when God is ready to take me, he'll take me. They don't want to have the conversation. So the counseling is very big. So I'm wondering if you have social workers first of all in your program to do that, and also from Rabbi Wolpe, also how would you initiate a conversation with somebody who's somewhat resistant to doing this?
Go ahead.
I was going to say, go ahead. Here's how I do it. I say, I could leave my practice today and be hit by a truck. Could happen to anybody, could happen to me, could happen to my child. And I want to make sure that somebody I trust is making decisions with my doctors if I'm unable to participate. And I discuss this with all my patients, not because I think you're dying, not because I think anything's about to happen. It's like wearing a seatbelt. It's like having automobile insurance. You have to let us know who you trust to make medical decisions on your behalf if you can't make your own. It's a requirement of New York State law that your family cannot make decisions on your behalf unless you have designated them. I have never had anybody turn me down. The only people, when I approach it that way, the only people who turn me down are ones who have multiple children and are afraid of selecting one child above the others. And even though it is not 100% concordant with New York State law, I let them write down every child and every child's phone number. Because in reality, we will not go forward with any decisions until the family is together. The reality is we will take what time it takes to get to a consensus in the family. And, of course, that's what the parent wants. They want the family to be whole through this process, and that is the highest priority. So I have written 8 children, adult children, and their phone numbers and their email addresses on this little space on the New York State Healthcare Proxy Form. And then at least there is someone. And then, of course, the logical next step is to let those people know, and that's kind of opens a window for a conversation.
The only thing I would say is actually the same theme, and then I'm going to contradict everything I said earlier. The same theme is that you can, one of the ways that you can open the conversation is by saying, what is it that you want your children to think about where you'll be, or how they should think of you after you die. I mean, sometimes that's the Archimedean lever that will pry open what others. But if someone really doesn't want to have the conversation, then it's better probably for them not to have the conversation. Not everybody wants to talk. That's our model. We're all talkers. But a lot of people don't want to talk, and they'll find it much easier if you don't open all these areas of anxiety that otherwise would remain closed, and they will die silent and more happily than if they die talking. So.
Yeah.
Medical students today taught about family counseling as well as talking to the patient, that they include the family when they're telling them what's going on.
You wouldn't think I would. Medical students. Well, you wouldn't think I would answer this, but my brother is the head of the ethics center at Emory University and a bioethicist, and he does medical rounds and he talks to doctors about such things. So at least some do, but for a real professional answer.
The question was, are medical students taught about these issues?
Are they taught about the role of the family caregiver, the critical linchpin role of the family in the care of people with serious or chronic illness? And I would have to say it depends, unfortunately. I mean, every medical student knows what to do when someone comes into the emergency room with chest pain. It's like automatic. It should be equally automatic that every medical student is taught that the family is the reason this patient is still alive. And the family, the unit of care is the patient and the family pays. It's a privilege to care for a loved one, but the family pays an enormous price in terms of their own health, their financial well-being, their social well-being, their emotional well-being as caregivers, and that it is our obligation as health professionals to partner with families. And it is not a mandatory component of the curriculum.
Could you repeat the question?
The question is it something I would recommend patients talk to their doctors about beforehand? And the answer is yes. I think it's important for patients and families to feel more power than we do, and to recognize that we are our doctor's best educators, and that we are the customer, we the patient are the customer, and therefore we have influence. And you have to demand what you need, and you have to keep demanding what you need. And you have to be a squeaky wheel on top of all the other things you have to do, unfortunately. But the families that do that, in my view, get better care.
Yes.
I work in a hospital, and it's a hospital in Rockaway, where we have a small hospice unit. The model is present a different model. Once you're in hospice, you're no longer getting the medical aspect. Are you presenting the model now that you can get both within hospice? And how does the work play out in terms of reimbursement?
Okay, no. Once you're in, the question is, can you get both life-prolonging care and hospice at the same time? So hospice is one form of palliative care that is limited to the dying. As I was trying to point out, we don't know who's dying most of the time. We know people are pretty sick, but they might die in 5 years, 12 years, like Mrs. G, 1 year, 1 month. We don't know. I mean, she could have died on any of those prior pneumonias that occurred over a period of years, but she didn't, not till the 5th one. So no, hospice would not be appropriate to someone who might continue to benefit from medical care, from life-prolonging medical care. And that's why hospice is a subset of palliative care, the subset of palliative care that is limited to those who are predictably dying and who are no longer benefiting from life-prolonging treatment. However, in the new health reform law, I am very pleased to say that there's a very exciting pilot that will occur at 15 sites across the country, which is called the simultaneous care model, where people can get both hospice and life-prolonging treatment at the same time. Now, I hope and pray that that study is properly designed and targeted so that we find not only better quality, but no increase in cost. If there's an increase in cost, they won't continue it. It has to be at least budget neutral. But that's the way it should be. We shouldn't force people to choose between effective life-prolonging treatment and hospice. And right now, we force people to choose.
Since I have to go, I just want to make one final point. I'm sorry that I have to run out, but The other thing that is, and by the way, if anybody has other questions, you're welcome to email me at dwolpe@sinaitemple.org. Stephanie has my email, and you're more than welcome to do so. And that's actually what I want to make my final comment about, the Internet. About 6 months ago, the guy who runs eHarmony, which is the big Internet dating service, who's a member of my congregation, took me out to breakfast and told me how to get a Facebook page. And he said, why don't you have one? I said, because I'm a rabbi. And he said, do you want 18-year-olds to hear anything you have to say? And I said, yeah, I do. He said, so get a Facebook page, which I subsequently did with his help. The Internet can be an incredibly powerful tool, especially when families are all over the place, caring pages, other things. If you don't know about it, it behooves you to become familiar with it. When kids can keep in touch with someone who's dying when they live in Thailand by continually posting on someone's care page. I know many people, unfortunately, who have died. Their friends continually have posted both during the dying process and after their memories of them. And the most important thing you can tell families, and I'll close with this, is when someone, especially when a parent of young children died, what I say at every funeral, and I encourage you to say it too, is to all their friends immediately write down every memory you have of that person. Because one day those children will want to know who their parents are, and the friends are the treasure house of all the memories that the family can't tell them about. And those are the kinds of things that the Internet does brilliantly, Facebook pages, caring pages, and so on. And it's a very important tool that we too often neglect because we think of it as trivial, but it's not. It really isn't. Even though it's not the same as being there, it's a virtual community, and virtual means not real, but it can be social networking is really an important development in our time. So anyway, thank you very much. Sorry I got to run.
We were indeed fortunate to have Rabbi here as long as he could stay, and we're still here. So for additional questions for Dr. Meier, yes.
If you go off on a trip, should you carry a copy of
Come on
your
up.
healthcare proxy with you?
The question is, if you go on a trip, should you take your healthcare proxy with you? Yeah, you can get them made into little wallet cards. If you get hit by a truck in San Francisco, who's going to know who to call? So yeah, it's very, very helpful. I would say 99% of the time we have no idea. When people who are comatose come into the ER, we don't know who to call. We don't know how to reach anybody. Decisions get made by default because we can't talk to the person who knows what the patient's goals are. Yeah. The question is, what do we do about developmentally disabled or mentally retarded people who now, thanks to modern medicine, do live to middle age or old age? There's no prior expression of wishes. No one could know what they wanted. In New York State, in the absence of wishes from the patient, there is no choice other than the delivery of aggressive life-prolonging treatment, although we just passed the Family Healthcare Decisions Act a couple of months ago after 15 years of Sturm und Drang, which will enable families to make decisions on behalf of a loved one. But prior to that, we could not. All I will tell you is that it always involves hospital legal. Our hands are always tied because if we don't know and the person never had the capacity to express wishes previously, the obligation as hospital legal understands it is to do everything. And we cause a great deal of misery in so doing. So a lot more publicity about what you're describing is necessary in the healthcare system.